Okay, I want you to think about the very last time you got a tiny paper cut, maybe a minor scrape on your knee, or even a mild burn from the stove. In the exact moments that followed, a highly coordinated, incredibly complex defensive war was actually waged right under your skin. Today, we're going to literally map out the exact strategy your body uses to fight back against injury. It's a great question, isn't it? I mean, why does a tiny paper cut get so incredibly red, hot, and swollen? We usually just view these everyday clinical symptoms as annoying side effects of getting hurt. But in reality, those symptoms are the visible proof of an intense, carefully orchestrated biological response. Every single ounce of that swelling, redness, and heat, it's completely intentional. So here is the roadmap for our biological military operation. First, the core mission. Then, sounding the vascular alarm, leukocyte deployment, the chemical messengers involved, the visual patterns of the aftermath, and finally, how the battle actually ends. All right, Section 1, the core of acute inflammation, defining the mission. Okay, let's dive into this. Before the body sends in the troops, what actually is acute inflammation at its core? Basically, it's a high-speed delivery service. It's designed to rush leukocytes, those as your white blood cells, and plasma proteins straight to the site of the injury. And once they arrive, these cellular troops have very clear orders. Clear out any foreign invaders, like bacteria, and start digesting and getting rid of dead, necrotic tissue. This entire process relies on vascular alterations to boost blood flow, structural changes to let those troops out of the bloodstream, and then the physical emigration of those leukocytes into the tissue itself. Moving right along to Section 2, sounding the vascular alarm, the body's highways. Now, to get the troops to the front lines, the body literally has to modify its highway system on the fly. These foundational vascular events undergo rapid structural changes. Think about it. To get white blood cells from inside the blood vessel to the actual cut on your finger, the vessels have to alter their flow and their physical structure. The circulation system essentially transforms from a closed loop into a highly permeable deployment zone, permitting those crucial plasma proteins and leukocytes to just step right out of the circulation. This transformation happens in a rapid sequence of 3 steps. First up, we have transient vasoconstriction. For just a few seconds, the vessels tighten up. It's an immediate reflex. But almost instantly, we hit step 2, which is vasodilation. The vessels widen, opening up new capillary beds and massively increasing blood flow to the area. And this increased blood flow is the exact reason why the site of a cut feels hot to the touch. That's calor. And looks red, rubor. Finally, step 3 is stasis. As protein-rich fluid escapes the vessel, the remaining blood becomes much thicker and more viscous. This slows down the flow and causes a literal traffic jam of red blood cells, which perfectly sets the stage for the next phase. But how does that fluid actually escape in the first place? Well, the vessels have to become intentionally leaky through a few main mechanisms. The absolute most common one is endothelial cell contraction. The cells lining the blood vessel physically pull back, widening the gaps between them for about 15 to 30 minutes so proteins can squeeze out. Now, sometimes the injury itself, say a severe burn, causes direct endothelial injury, leading to cell death and detachment, which leaves huge gaps. And lastly, there's increased transcytosis. This is where intracellular pathways actively transport fluids and proteins straight across the endothelial barrier. So, the alarm is fully sounding and the highway is completely open. Which brings us to Section 3. Leukocytes enter the battlefield. Deployment. This journey is an absolute masterclass in cellular choreography. Because of that slowed blood flow we just talked about, we start with margination. The leukocytes are pushed to the very edges of the blood vessel, hugging the walls. Next is rolling. They tumble along the endothelial surface, briefly sticking to molecules called selectins. It's kind of like tumbleweeds catching on Velcro. Then comes firm adhesion. Integrins on the leukocytes lock on tightly to endothelial ligands, stopping the cell completely in its tracks. Finally, transmigration, or diapedesis. The leukocytes literally squeeze through those widened intercellular junctions using a molecule called CD31. Once through the wall, they secrete collagenases to punch through the basement membrane and step right out onto the battlefield. Now, what's really fascinating about this slide is this final step, chemotaxis. Once the leukocytes have squeezed out of the vessel, how on earth do they know where the actual injury is? Well, Much like a rescue dog following a scent trail, leukocytes migrate toward the injury by tracking chemical breadcrumbs, things like bacterial products, cytokines, and complement components. They are drawn directly to the site of maximum danger. And once they arrive, oh man, the actual combat begins. This is phagocytosis. The leukocytes recognize the enemy with the help of opsonins, which are essentially target markers painted right on the invaders. The white blood cell extends its membrane, physically engulfs the threat into a pouch called a phagosome, and then it unleashes absolute devastation. It generates a respiratory burst, creating highly toxic reactive oxygen species, literally things like hypochlorite, which is the active ingredient in bleach, alongside degradative lysosomal enzymes. It completely destroys the invader.
Let's move to Section 4, Chemical Messengers of Inflammation, Battlefield Comms.
You know, a massive military response like this would just descend into total chaos without a solid communication network. It's amazing to see how the body manages this. For example, check out histamine at the top there. Released by mast cells, it's the primary driver of that initial vasodilation and leakiness we discussed. Then look at prostaglandins. When you have a throbbing pain at the site of a cut, or when an infection gives you a fever, prostaglandins are directly responsible for that. Leukotrienes help guide the troops via chemotaxis, while kinins, like bradykinin, contribute heavily to both vascular permeability and that sharp, immediate pain of an injury. So these mediators, whether they're derived from local cells or they're circulating plasma proteins produced in your liver, they are the true underlying culprits behind all the clinical symptoms you experience. Seriously, every single time you reach for an over-the-counter anti-inflammatory drug, you're actually just trying to intercept these specific chemical communicators.
Section 5. Visual Patterns of Inflammation, the Aftermath.
Pathology actually shows us distinct visual patterns of this war's aftermath depending on the severity. First up, there's serous inflammation. If you've ever had a skin blister from touching a hot pan, you've seen this firsthand. It's a watery, cell-poor fluid filling a space. Next is fibrinous inflammation. When vascular damage is more severe, massive proteins like fibrinogen escape and deposit this sticky, fibrous web. We commonly see this in the lining of the heart. Then we have purulent or suppurative inflammation. This is characterized by the production of pus, which is just a thick mixture of dead neutrophils, liquefied tissue debris, and fluid. This is typical of pyogenic or pus-forming bacteria like staphylococci, creating localized abscesses. And finally, ulcers. These occur when inflamed, dead tissue physically sloughs off, leaving a literal excavated defect on an organ surface. Finally, Section 6. How the battle ends. Outcomes and peace treaties. And this brilliantly illustrates what happens after the invaders are neutralized. There are essentially two main pathways for ending the war. On the left, we have the absolute ideal peace treaty, complete resolution. The chemical signals naturally decay, the surviving neutrophils undergo a controlled cell death, and then macrophages step in as the cleanup crew to clear out the debris before the lymphatic system drains the excess fluid away. It's almost as if nothing ever happened. But on the right, we have the backup plan, scarring or fibrosis. If the tissue destruction was just too immense, or the local tissue simply can't regenerate itself, the body patches the battlefield with connective tissue. The function of that tissue is lost, sure, but the physical breach is sealed. However, there is one final, really crucial outcome we have to consider: progression to chronic inflammation. What if the acute response just cannot eliminate the offending agent? Maybe it's a persistent viral infection, a really tough bacterial strain, or an autoimmune disease. Well, the body refuses to give up. That fast-acting acute battle transitions into a grinding, prolonged, long-term war, utilizing entirely different cells and entirely different strategies. So the very next time you get a simple scrape or a paper cut, I hope you remember the incredible complexity of what's happening just beneath the surface. It's not just a nuisance, it's a masterfully coordinated vascular and cellular symphony that is literally designed to keep you alive. It really leaves you wondering, what unseen microscopic battles are happening inside your body right now? Thank you so much for joining me for this explainer. Keep learning.